I'm Dr. Jamshaid Anwar, one of the interventional radiologists here at Shifa International Hospital, and I'll be talking about abdominal aortic aneurysm repairs. So basically constituting infrarenal abdominal aortic aneurysms, endovascular repair, obviously. My only disclosure is that I've been an invited speaker for the Medtronic Masterclass Endovascular, which is a webinar last year. So the outline, I only ever remember three things. I'm going to talk about three things today. I'll talk about EVAR theory and evidence. I'm going to present some cases of abdominal aortic aneurysm repair endovascularly in Shifa, and I'll talk about endoleaks. So before we say anything else about endovascular aneurysm repair, the main thing is that you need a team, you need the support, you need that environment where you can provide the service. And listening to Dr. Umar's excellent talk just now, I'm wondering whether he has a hidden passion to be a radiologist. So you can tell how closely we work together, because he had all those excellent videos of all these the varied aortic pathology that we see here. And of course, I can see Dr. Atif Rana here, who's our head of interventional radiology, and his support, and which made it all happen, really. So we've all worked together here. We're four interventional radiologists, and Dr. Umar is an endovascular surgeon. We've got Dr. Harris now, who's a cardiothoracic surgeon and does a lot of aortic work as well. And that's the essential thing. You need that sort of team. And we've got two dedicated interventional radiology suites, which is where these EVARs occur. And we do vascular MDTs. We had one this morning. So all of these things. So it's important when you're setting up this sort of service. So we all know what an abdominal aortic aneurysm is. It's an abnormal dilatation of the aorta, more than 1.5 times its normal diameter. And the main treatments that we have, the main options that we have, are endovascular repair and open surgical repair. There have been a number of trials looking at EVAR versus open surgical repair over the years, and these are the main ones, and I've sort of put them down in the order of how many patients were recruited for each one. So from the one that recruited the most patients, the ones that recruited the least. And I'll just go over them very briefly. I realize it's late in the afternoon on Friday, and I don't want to bore you with too much evidence, but it's interesting to go through all of this as well. So the EVAR-1 trial, not very imaginatively named, was the UK trial. And this is the biggest trial. They had the biggest numbers. And essentially what we saw was that there's an advantage early on in the first 30 days with operative mortality. It was a multi-center randomized controlled trial, and the main thing I want you to concentrate on is the numbers. 1,252 cases, which were randomized to either EVAR or open surgical repair, about 626 each. And as expected, there were more males than females, which is just the pathology. That's how aneurysms present. And the primary outcome was all-cause mortality. The VA OVER trial, which is a US trial. I thought that'd be a really neat name if it was a cricket-speaking nation that had come up with it, but I don't think it has anything with to do with the cricket over. But the OVER trial is the open versus endovascular repair, and this was done in the US. And the interesting thing to note here is the dates of when these trials are occurring. So if the EVAR-1 trial is really quite old now, and this is, of all the trials I'm going to talk about, probably one of the most recent ones, and this is from 2002 to 2008. So that's something to bear in mind, because obviously the expertise, the hardware and things have evolved since then. So this is something to bear in mind. I'll touch upon that in a few minutes. So in this case, there was about 881 cases, EVAR 444, OSR 437 randomly assigned. And again, the main thing, the gist is that everyone wants to look at long-term all-cause mortality, and that's what they looked at as well. And a much more imaginatively named trial, the DREAM trial, was the Dutch randomized endovascular aneurysm management trial. And this was between 2000 and 2003, less cases, you can see 351 randomized to both. And again, a number of outcomes, but one of the main ones is all-cause mortality. And finally, this is a French trial, the ACE trial, and 306 cases randomized open surgical repair or EVAR. Now, luckily, we've got something in the UK called the Cochrane Review, which does really good meta-analyses. This is from 2014, and they do all the work for you. So they look at all these randomized control trials. And they've put them on this. And you can see that for short-term mortality within the first 30 days, EVAR seems to have an advantage over open surgical repair. You can see that all of those lines with the confidence intervals are to the left of the null hypothesis, and that's favoring EVAR. To the very bottom of the screen, you can see the left side favors EVAR and right side favors open repair. They looked at a number of different analyses, but one thing that was quite significant was that for pulmonary complications, EVAR came out on top. There were less pulmonary complications. So patients who were really sick with really bad COPD, pulmonary fibrosis, EVAR may be a better idea if it's possible. And the final thing that I want to point out here is reintervention rates. And this could be considered Achilles heel of EVAR because we know that there is a higher reintervention rate. So here it's favoring open surgical repair. So these patients do have a higher intervention rate, but you know the reinterventions may not be that invasive. EVAR itself is not invasive, and it's something that that can be dealt with. But we'll talk about all of these things in a bit more as well. Coming back to present day, so we just talked about how all these trials are quite old, and the disadvantage of having these trials that are quite old is that they're based on older technology and the early days of experience, perhaps. The good news is that we also have this data for long-term available now, long-term mortality. And all of these groups are now going back and looking at long-term mortality and trying to tell us, give us some more fine information about that. There's been a little bit of a controversy. Some people, the two studies that were done in Europe seem to suggest that what's happening is that you have this advantage of survival early at 30 days, but in the long run, after 8 years or so, maybe that survival advantage doesn't hold. And in EVAR1 and DREAM, the recent reanalysis has shown that perhaps the lines converge, and maybe that there's more lower survival long-term in EVAR patients. However, the OVER trial, which I think it was quite recent in 2019 that they've done this update looking at the long-term survival in the US, they don't see any difference in long-term survival. So the jury's still out on that. This is another meta-analysis that was done in 2019. But it's not just an analysis of randomized controlled trials. They included all comers. They included all case series and observational studies and anything that we get their hands on. And this was just before OVER published its updated long-term results. So I don't think they've taken that into account. But they sort of suggested that, maybe in the long term, all-cause mortality, it's a bit higher in EVAR than open. However, they also made a very astute observation, and they said the sub-analysis of more recent studies within the last year of patient recruitment or after demonstrated no long-term mortality differences between EVAR and open surgical repair. So I think it has to be a bit more nuanced look at this, and we have to take all those things into account. So what are the indications for EVAR? This is a vascular surgery audience mainly and interventional radiology, but we all know that when once it reaches a certain threshold, the risk of rupture is high enough to warrant elective repair, and that's usually 5.5 centimeters. The rate of growth is important. So if it's increasing in size quite rapidly, again, there's an indication. Saccular infected or mycotic aneurysms can be treated. I think Dr. Umar showed a case that was treated with open repair. And it seems counterintuitive to put in stent graft in an infected aneurysm, but we can and do mycotic aneurysm repairs as well. And finally, ruptured aneurysm repairs, which is really I think Dr. Moore was talking about how some vascular surgery cases can be quite run-of-the-mill, and you need that slight thrill to bring back the excitement. And this is where, as an endovascular aneurysm repair person, you really enjoy, because with the ruptured, aneurysm repair, you need to think fast, you need to think on your feet, you need to work off the shelf. The problem with that is that we don't have all sizes of stents available on shelf. They're very expensive. We have to order them in. So it's something we can't offer here at Shifa at the moment, but it's a really interesting space to watch. If a patient has an aneurysm that can be treated endovascularly, the results are quite good. You do have to have, really know your stents and know your sizes and know how to work around issues, because essentially you're working in an emergency situation with whatever you have on the shelf. And there's situations where you don't have that luxury of planning. Say the iliac artery is really diseased, you might have to put in a stent in the iliac first. Usually you put in the main graft, and then you seal the limbs in the main graft in the body. But in this sort of situation, you might have a really diseased iliac, all sorts of weird, wonderful things like pave and crack, where you put in the limb first, open that up, and then flower pot the main body through that. So it's really, really cutting edge and interesting for an endovascular surgeon, interventional radiologist. That's just something to think about as well. So planning is important. So everything I said about ruptured aneurysms is great because you don't have any other choice. You just have to wing it and work and think on your feet. But essentially for most of your 99.99% of your aneurysms will be elective. And those are the ones where planning is absolutely essential. Planning is probably most of the work. And as the old adage goes in surgery, plan twice, cut once, and that couldn't be truer in endovascular aneurysm repair. So you need to work up, you need imaging to work up the aneurysm. It shouldn't be more than 6 months old. So if you have a CT angiogram, which was done yonks ago, done a year ago, that may not do because the aneurysm may have changed. It may not be the same size. And it's really good to have vascular analysis software as well. You need to know your devices. Broadly speaking, in my mind, you can have suprarenal fixation. We're talking about, infrarenal abdominal aortic aneurysms here. You have suprarenal fixation, infrarenal fixation, and there's some other. There's other things where you can like Nelix innovation, but not even going to the details of those. Essentially, most of your grafts would be suprarenal and infrarenal fixation. The anatomy is important. The neck. You need to look at where the lowest renal is on the scans, the length of the neck, the shape of the neck, whether it's conical, the reverse conical. Why have I still got this on? Rather, this just reminded me that I still have my mask on. Sorry, somebody should have mentioned it earlier. It's difficult to lip read when someone's got a mask on. Right, so the lowest renal is the most important. You need to see how many renal arteries there are, because there could be accessory renal arteries. You need to know which one is the lowest, so that you don't cover that. And the length of the neck is important to have an adequate seal. You don't want a conical or reverse conical neck ideally. You don't want a neck that's very diseased, where you can't have a seal zone, or very angulated. And we look at the diameter to dial in which main body graft we'll use. And the overall anatomy is very important on the CT scan. So things like a horseshoe kidney could mean that the IMA is coming right up off the neck of the aneurysm. And we've already talked about multiple renal arteries. The aortic bifurcation is important, because if the aortic bifurcation is extremely tight, then you may not be able to put in a bifurcated device. You may not be able to put in 2 limbs. And in that sort of situation, you might need to put in an aorto uniiliac device, or think of some other options. And the aneurysm size, of course, is important. It's important to decide which aneurysms to treat, but it's also important to plan your actual aneurysm repair. The main body graft has as we know, an ipsi limb and a contra gate, and the contra gate needs to be cannulated from the contra iliac. And that can sometimes be quite challenging, particularly if it's a massive aneurysm. It's a huge sac that you're going into from a small tube, i.e. the iliac. And you need to kind of plan, where will that gate open up? You usually try to open up anteriorly, but sometimes you even need to do a ballerina kind of deployment. So essentially with the legs crossed like that, so that when you're coming up from the contra, you're pointing to the opposite side, and you can actually then cannulate the contra limb more easily. And you need to know what the common iliac artery lengths are, or wherever you're landing, depending on your landing zone. And most importantly, you need to look at the access. If the common femoral arteries are completely occluded, then you need to take that into account. So it's something that we need to look for. So what is the aortic angle? It's the angle between the flow axis of the supra and infrarenal aorta. And the neck diameter that we're looking at here is on CT, and it's adventitia to adventitia. It's not from the inner to inner like you do on ultrasound, which is a screening tool in most countries. So you need to know your graft, and it depends on whatever make your graft is. We need to know the lengths of sealing zones and what angulation of the aortic neck it can take. Most grafts take about 60 degrees. There are very specific grafts that are designed for really angulated necks that can even go up to 90-degree angles. Most of these companies will give you sheets. So you find a cheat sheet. So you measure the diameter, you dial it into the cheat sheet, and it tells you what stent graft size you need. But it's good to have a mental idea, particularly if you're doing ruptured aneurysms and things like that, of what the working behind that is. And normally you're looking for 20% oversizing at the neck, roughly. And this is important. This is for aneurysms, not for dissections. Dissections, you do not oversize that much because you could turn a type B into a type A. But we're talking about abdominal aortic aneurysms here. And about 10% oversizing at the iliacs. Usually you need about 18 to 20 millimeters of the aortic bifurcation. You need to be cognizant of and aware of the fact that there's a gate that, that divides the flow in your main body. And you need to know your top end to gate length, because that's really important for planning the EVAR. It's usually about 7 centimeters. And you need to know for that graft what the minimum overlap is, because this is a modular thing. And you're usually using 2 or 3 grafts. So wherever the joins are, if that seal isn't adequate, then you're going to have a leak. And you need to have a really good idea of what your minimum overlap is and make sure that you're achieving that. These are the sizing charts, Endurant by Medtronic. These are the usual suspects, the main ones that we use. Zenith Flex by Cook, and of course Gore, which unfortunately isn't available in Pakistan, but those are 3 very kind of commonly used kits. The lowest renal, when I'm planning an EVAR, I do a little diagram on the back of an envelope, and I make sure I have this clear in my head. I've worked with people who actually put it on a whiteboard in the angio suite, which is not a bad idea. But you need to know what the lowest renal is, and you also need to know on a clock face where that lowest renal is coming off. And that helps you decide how you're going to set up your machine in fluoroscopy to be able to best see that. So you want to be orthogonal to it. So if the left renal is coming off at say 1 o'clock or 2 o'clock, I do a little diagram clock face. I have an idea of where it's coming off. I know that I need a right anterior oblique to be able to see that origin. And usually the neck is tilting backwards. So you need a cranial tilt to be able to open up the neck. It's important when you're measuring the diameter to have a true axial diameter. And these are curving arteries. They're not ever completely straight. And this is where vascular analysis software really comes in handy, because you can actually see the vessel and it gives you a 3D reconstruction. But I still think it's a really good idea to go off the main actual unreformatted imaging when you're looking at diameters as well. So just a quick and dirty diagram, the kind of thing I do in the back of the envelope for every case. So although each and every company has its own planning paperwork that you can fill and use, I like to do this thing on my own as well, just so I have a good idea of what we're doing. And the neck, you want usually about 1 centimeter. You want to look at the neck shape, you want to look at the angulation. We've talked about all of these things, but this is just a little diagram that I make on the back of a piece of paper. The neck, you usually want to look at 2 diameters, proximal and distal, to get an idea of if it's conical or if it's all the same. If it's parallel, ideally, in an ideal world, the neck is parallel. It should be parallel. And one thing I always do is I always have a sagittal look at the neck as well, because when you're looking for disease, it could be hiding posteriorly. and that really clears up on the sagittal view. When you're introducing your main body graft and the contra limb, which side is the main body and which side is the contra limb is up to you. It's something that you can decide. So you can either put the main body up the right common femoral artery or the left common femoral artery. Why is that important? Because the main body is usually bigger. It's usually a much larger sheath. And the contra limb is usually a much smaller sheath. So it's good to have a rough idea of where you're going before you start. And what you really want to do is you want your main body to go up the side with less curves. So you want your main body to go up the C side rather than the S side. And apologies if that comes out laterally inverted, but you see what I mean. There's two curves on one side and one on the other. This is just for arterial access. I put this in here. We're at the moment, we're doing all our endovascular aneurysm repairs with a surgical open cut down of the groin. In the UK, I've done loads of percutaneous EVARs. So we can actually close holes up to 18 French easily now percutaneously, which means that we can do an EVAR completely percutaneously. And I tell my fellows in interventional radiology this, that whenever you're accessing the femoral artery, you should access it axially at 12 o'clock, because this is good practice for when you use closure devices. It's essential that your access is at 12 o'clock for a closure device. And in an EVAR, your stakes are much higher because you're using two pre-closure sutures even before you make the arteriotomy bigger, and they have to be precisely placed. So ultrasound is really helpful for that. We don't have these here at the moment in Pakistan. It's expensive, probably. I think that's probably one of the reasons why we haven't gone down that route. When I think of ProGlide, or the first time somebody mentioned ProGlide to me, I thought of a shaving razor by Gillette, but that's not what this is. ProGlide is essentially a pre-knotted proline suture, and it has a delivery mechanism whereby you can deliver you deliver this suture into the arteriotomy, and then almost like a laparoscopic knot pusher, to the percutaneous nick, you can tighten the sutures at the end. And for EVAR, we use two of them, one placed at a 10 o'clock position and one placed at a 2 o'clock position. So it kind of forms an X. And we put those in before dilating the arteriotomy. So we start with a small French sheath, maybe 8 or 9 French, and then we work up to the 18 French, but the sutures are already in situ at that point. So this is established kind of thing, practice, and there's a Cochrane review on this as well. This Cochrane review is actually quite old, and I think it's probably should be up for review soon, because there's a lot more data as well. But even the Cochrane review shows there's absolutely no difference in complications. So it's not like you have a higher rate of hematomas or a higher rate of bleeding or higher rate of dissection. No, it's equally safe compared to open EVAR. In fact, there's a significant difference in operating time of about 31 minutes. So you need to know your graft. The graft has markers on it as well. These are radiopaque markers which tell you the top of the graft. They tell you whether it's, which way it's pointing. And we'll talk about that in a bit more detail with pictures afterwards. And you need to know about if you've got flared limbs and things like that. And we've talked about the execution angles for fluoroscopy and stuff like that. Essentially, I probably didn't mention the iliac bifurcation, but for iliac bifurcation, you usually need a little bit of caudal tilt and a contralateral anterior oblique to really open up the iliac bifurcation. So you can be absolutely certain that if you want to save the internal iliac artery, which is the case for most EVARs, that you can, and you don't cover the internal iliac artery inadvertently. And of course, we need to follow these EVARs up because we know that there's a reintervention rate. So CT angio, some places use X-ray and ultrasound, but I think really as we're moving forward, we're looking at CT angio. So a few cases that we've done here in Shifa. We've done a lot of thoracic abdominal aortic aneurysm repair, and Dr. Zaid will talk about that in a little bit. The abdominal aortic aneurysms, we've done about 6 cases, so they're not that many at the moment, but I'll go over them with you quickly. This is state-of-the-art stuff, and I had to include this when I was asked for this talk. This is, I trained in the UK and Scotland, and I was driving by this shop in Edinburgh, And I just thought it was a really interesting name for the shop. So it's a gallery, the artery gallery. But what we do is state-of-the-art vascular stuff as well. So the first case is a 75-year-old gentleman from the UK. He presented with an acute ischemic right leg, and while he's being worked up for that, was discovered to have an abdominal aortic aneurysm. And we've been following up this case over the telephone. Dr. Umar tells me he's spoken to the patient a number of times over the years, and he's fine. And you can see this is quite a large intrarenal abdominal aortic aneurysm that was repaired endovascularly with a good result. Second case is a 77-year-old female. This is a female who had pulmonary issues, pulmonary fibrosis and COPD. So we just talked about how those patients do better actually after EVAR than open surgical repair as well. And this patient had an abdominal aortic aneurysm picked up quite some time back, 20 years ago, and was gradually growing and reached the threshold for treatment. And we decided to go ahead. She had a left hip replacement. You can see these pictures here. The top left, you can see the neck is, it's a nice long neck, albeit quite angulated in the sense that this is an axial slice, and you can almost see the entire neck in the axial slice. And there's an adequate bifurcation, bottom left, and the bottom right, we always do that little picture looking at the access, looking at the common femoral arteries. You can see there's a left hip replacement, obviously. But that's the aneurysm itself in the middle of all of that. It's quite big. So that's during angio, and then the CT angiogram afterwards, so showing the endovascular repair. There's another case of a 77-year-old male, again, successfully treated, but there was a small type 2 endoleak, and this is an axial image. You can see that there's a left lumbar endoleak. Type 2 endoleaks are quite common. I'll talk about them in a little bit more detail towards the end of my presentation, but essentially, this patient had an attempted endoleak closure. We couldn't close it, but the aneurysm didn't increase in size. I'll talk about that in more detail in a bit. This is an 82-year-old who had, I think Dr. Umar had mentioned earlier, who had a treated lung cancer and was status post pneumonectomy and had this abdominal aortic aneurysm. The difference here is that the neck is non-existent. It's a juxtarenal aneurysm. You can see that immediately. So this is a challenge. It's not for a conventional EVAR. And what we did here was a fenestrated endovascular aneurysm repair. So with the fenestrated endovascular aneurysm repair, we need to get a bespoke tailor-made graft from the company, which is designed for that very patient. It can't be used on anybody else. It's a stent graft that has fenestrations or holes for exactly where these arteries are coming out. And it takes quite a few weeks to order. So this is something that requires quite a bit of planning. And this is during the deployment. This is during the actual aneurysm repair. And you can see that this is the graft coming up. The important thing with the graft's just on the right side of the aorta. There's a pigtail there for doing the run. And what you can see is that this graft has loads of markers on it. And it's really important to know exactly what markers represent what. There are markers for the SMA fenestration, the celiac fenestration, and for both the renal fenestrations. And if you get everything lined up correctly, when you deploy it, you can see these 4 markers at the top here, opening up. Let me see if I can get the cursor there. And similarly, we have markers on the right side here for the right renal, and markers here for the left renal. So it's really important that you really plan twice and cut once. You don't want to deploy this graft rotated or incorrectly. You want to be absolutely certain that the fenestrations are in the right place. And then each and every one of these arteries is cannulated and stent grafts are placed, and they're flared centrally. So you ensure that these branches are all patent. Then after that, it's more like a regular EVAR. You have a main body graft, which is bifurcated in 2 limbs or 1 limb, depending. This is the end result here. So you can see that aneurysm has been successfully excluded. The branches are all patent. There was a little bit of difficulty I think cannulating the right renal artery, which you saw there, was slightly stenosed as well, but it was all fine in the end. The next case is a 72-year-old male with coronary artery disease. Almost all these patients have some form of coronary artery disease out there, but the diagnosed or undiagnosed is a different question. And peptic ulcer disease, renal stones, had a cabbage and PCI. And on the coronary CT angio, there was an incidental abdominal aortic aneurysm. These are the 3D sort of images. And I just want to draw your attention to this branch here. I don't know if you can see my cursor, the white cursor here, but that was an inferior mesenteric artery, which usually comes off much lower. But this is coming off quite high, quite close to the neck, and it's something that immediately caught our attention. So these are the cross-sectional images. You can see the left renal. You can see an idea of the neck, and you can see that as we saw on that 3D image, that this is the IMA here, which is coming off quite high up. So this is during the endovascular aneurysm repair. We always get the do an angiogram, and oftentimes what we do is we do the first angiogram with the main body graft up, because it's a stiff kind of structure and can change how things look. But here we wanted to address that IMA first. So the plan here was, because of the position of the IMA, we thought there'd be quite a high risk of a type 2 endoleak. And I'll go back to types of endoleaks right at the end. So we wanted to embolize that. We got in, we embolized that preemptively. And then we went on with the aneurysm repair. You can see the markers at the top of the graft here. And you can see the crown at the top. This is a suprarenal fixation device. And this is where the covered stent starts. So you don't want your markers to be above the lowest renal artery. And this is where that thing that I talked about getting the right angles with the fluoro is absolutely crucial. So if you're looking at the top of a glass and you can see a semicircle, that means you're not truly lateral. You want to see a line. You don't want to see the circle. And similarly over here, we wanted to see all these top graft markers in a line, which I think we have. They're not above and below each other. So we're absolutely certain that we're dead on and that we're not inadvertently shuttering the left renal artery. And you can see here the coil in the IMA that we just coiled prior to that. So this was successful, both internal iliac arteries, patent at the bottom, aneurysm successfully excluded, and we dealt with that IMA preemptively as well. So this is the last case. I think I asked them to give me a warning bell, but I don't think anybody has. I think it's probably close to about 30 minutes now. So this is a 73-year-old male, infrarenal aortic and bilateral common iliac artery aneurysms. And Dr. Umar showed us the whole video of this, images. And ideally, you'd like to do an iliac bifurcated device, but for technical reasons, we couldn't do that here. We did successfully exclude this aneurysm, sealing in the external iliac arteries and purposefully covering the internal iliac arteries. The patient's well, luckily didn't have any buttock claudication or symptoms from that. You can see all these images, but there was this tiny endoleak, a type 2 endoleak on the post scans. And that's just a handy segue to go to the final part of my talk, which I think you'll be glad to hear because it's been a long talk, which is endoleaks. So we all know there's various types of endoleaks, and this is really important to know because endoleaks are common. And when you have reintervention in EVAR, a lot of times it's because of endoleaks. Some places report up to 20% of patients can have endoleaks afterwards. And by far and away, the most common type of endoleak is a type 2 endoleak. About 40% of your endoleaks are type 2 endoleaks at least. But the ones to worry about, obviously, are your type 1. They're the worst endoleaks to have, a 1A or a 1B. So 1A endoleak is if your top seal, the neck, infrarenal neck, isn't working for whatever reason. And these are endoleaks that you generally pick up during the procedure rather than after the procedure because you want to address them straight away. That means the aneurysm hasn't been excluded. Or a type 1B endoleak, which is the bottom end, which is where your usually common iliac seal zones are, but you can also see the external iliac depending on the case. And if there's a leak from there, then again, your aneurysm has not been excluded. It can be pressurized and it can still rupture. So that's something you need to deal with straight away. A type 2 endoleak is commoner, but usually less of an issue. And a type 2 endoleak is basically where you have reverse flow or backflow from a branch artery. So there are lumbar arteries that we don't close here. Usually we don't occlude the IMA, and sometimes there can be retrograde flow through those arteries that starts filling the sac, and the sac can be pressurized. There's two types of type 2 endoleaks, type A and B. A is if there's just one vessel going in, and B is if there's more than one vessel going in and out. And then type 3 is if there's a problem with the graft, if there's a rent in the graft, or if there's a problem with your junctions, your seal zones. And then type 4 and type 5 are sort of your phantom things, which you don't generally see very much of. But type 4 is thought to be that there's an increase in tension in the aneurysm, an increase in size, and it's thought to have something to do with porosity of the graft. I think this is more of a historic thing. Early days when these grafts are being developed, they were probably a bit too porous. And type 5 really is when we don't know, but there's endotension, there's increase in size of the sac. So we've talked about type, we've talked about how these need to be followed up. What are the treatment options? Quick and easy, simple things. If you have a type 1A or 1B endoleak, we have a compliant molding balloon. During the procedure, we need to use it. Simple, straightforward. We always do a contour ballooning, regardless of whether there's a leak, but if there's a leak, you do it a bit more aggressively. And normally, usually, most of the time, that apposes the stent graft to the seal zone, and the type 1 endoleak is treated. There are other things that you have in your armamentarium. You can put in an aortic cuff, which is a slight extension, if there's a type 1A endoleak at the top end, which helps stop that. And if there's a type 1B endoleak, then sometimes you may be forced to just extend the iliac distally to where you don't have a leak, because maybe that artery is very diseased and there's a problem there and it's not sealing very well. And finally, Medtronic, I think, have lead the market with this, with their HeliFix endo anchors, which are very handy, and they do what they say on the tin. They anchor the graft at the neck. So what usually happens is you have one A leak because that graft is maybe migrating down or is just not quite well fixed enough to the wall or apposed enough to the wall. And these are really like these little kind of pigtail kind of anchors that just tack it there using a directional sheath. And that's what they look like. So type 2 management. Type 2 endoleaks are by far and away the most common endoleak that you see. For all of the radiologists out there, you need to really look for these. They're common. They're not usually a problem, but they need to be mentioned and they need to be surveilled and kept an eye on. You can treat them conservatively. If they're not increasing sac size and there's no problems, just keep an eye on them. And oftentimes they resolve on their own. But if there's an increase in sac size, then you need to start thinking about treating these type 2 endoleaks. And we've got a number of different options here as well. We can embolize these endoleaks. We can do direct sac injections with onyx and things like that. And then we have to remember and not be in a silo that we're not on our own. The surgeons can help interventional radiologists with non-endovascular approaches like laparoscopic clipping of arteries causing type 2 endoleaks. So this is the case of the EVAR that had an endoleak from the IMA. And you can see it's quite a long way around, getting into the SMA, doing the angiogram, and then getting all the way to the IMA and coiling the IMA to prevent this endoleak, stop this endoleak. That's the lumbar endoleak. Again, this is usually, if you do want to treat these, you'd approach it by the internal iliac artery branches. So you need to localize the endoleak, know exactly where it's coming from. If it's a type 2, how many are there? You need to know your anatomy of how to get there. So if you're getting from the SMA to the IMA, for instance, you need to know about your collaterals. If you're getting to the lumbar arteries, you're looking at internal iliac artery branches. And if you can't get there, you can go CT guided straight into the sac at the site of the endoleak and inject stuff there like onyx. Finally, if you want to be in this business of treating endoleaks, type 2 endoleaks, you need long microcatheters and a lot of patience. So this is the IMA that we preemptively embolized. And this is a case actually in the UK, again, similar theme, going from the SMA all the way around, long way around with the microcatheter to the IMA for a type 2. That's all I think we've got time for. Thank you very much.